I wanted to welcome JD Whitlock, who is the CIO from Dayton Children's Hospital, headquartered out of Dayton, Ohio. Great to get a perspective from here in our own territory of Ohio. And so we kind of started this morning with some national perspectives, or actually some global perspectives, and then down to some national perspectives, and maybe bring things a little bit closer here to home. So JD, I'll let you explain to the audience. It sounds like, from what I understand, you've gone through several different iterations of a title for this conversation today. So
yeah, I wanted to talk about what's going on today and in the future for interoperability. And we can't. Ajay and I were joking about like how alarming to make the title. So we went back and forth between what to call it. But anyways, we're going to talk about interoperability, obviously a hot topic. And what I'd like to do is I want to go backwards in order to go forwards a little bit. I know from attending many previous CSOHIMSS conferences in years past that it's really a minority of the audience that what I would call practitioners of healthcare IT working in health systems. And I noticed the same thing this morning when I was looking at the Zoom during the keynote this morning. Many names I recognize, organizations I recognize, and then a lot of vendor domains, a lot of Gmails out there. I know we have a lot of students. We have vendors that sponsor these events. Thank you. And some of their staff are attending in order to get smarter on hot topics like interoperability, but may not necessarily have a lot of background. So I'm going to do a little bit of history here. That's going to be review for some of you, but I think it's a good groundwork for everybody else. I'll go through that pretty quickly. Then we'll talk about where are we today in the interoperability journey 6 months after really sort of radical change from a regulatory perspective, right? Back in April, we'll talk about that, and some thoughts on where should we be today, given where we are with the standards. Then we'll talk about looking ahead for some things that are coming in about a year from now. And then lastly, I'll tie it up with some thoughts on what does this mean for you as a patient, because we are all patients and we need to think about some of the implications of all of this for our own family's care and the security of our own family's protected health information. Okay, so history lesson. 1996. Oh, by the way, I meant to mention this. I chose August 1996 to May 2020. Those are very specific dates. August 1996, that's when Hipaa, the Hipaa law went into effect. And May of 2020 is when the Cures Act, the final rule for the Cures Act, sometimes known as information blocking, was effective. That's the reasons for those dates. Okay, so back to 1996. Hipaa is passed. Coincidentally, I am in my very first healthcare job in the Air Force Medical Service at Barksdale Air Force Base in Shreveport, Louisiana. And this picture gives me a little bit of PTSD because my first job was the flight commander for the medical records department, because in your Air Force, you get goofy titles like flight commander. And I had a team that had to track down all these paper records and keep the paper updated in the right records, and we had to chase down the small minority of providers that would stack records up on their desk and take forever to do their notes, because then the patient would come in for a consult someplace else, and guess what? Paper records can only be in one place at one time, and they wouldn't be available for the patients. So it's not, well, it is long ago, it was 25 years ago, but that's this reality that healthcare live with. And of course, we're not completely free from paper yet, but it is worth noting that that's what we're mostly free of today, A, and B, the rights that patients were given with Hipaa, that you own your own information and you have right to that information, and you can go to your doctor at the hospital and say, I want to get all of I want to fill out this form for release of information and get everything in my medical record, or almost everything. That right has been around since 1996. And all of this healthcare interoperability stuff we're going to talk about is about how we can get it in a faster, easier, more computable, more useful way. But the right to the data has been there for a long time. Okay. This form this is the Dayton Childrens authorization for release that we have today still. We had, I don't know if it was this exact form, but the types of forms that happened in 1996. And you got to choose what records you wanted to get. And there's, of course, it would be a nominal fee if you're getting this, per page if you're getting paper. Then the law allows nominal administration fees for getting all of this data, right? Because somebody has to do that. There's some bunch of manual work. Okay, and so that is still present. A lot of confusion about what HIPAA is and is not. We're going to talk about that a little bit later. There's a really important new thing about what HIPAA is not when you're releasing your own information to some of these health apps that we now have the technical ability to do. And that's something we need to think hard about. Okay, HIPAA, we also need to appreciate that HIPAA has teeth. There's major monetary penalties for health systems that have breaches. You can have millions of dollars of liabilities if you have a large HIPAA breach. In this case, Banner Health, 3.7 million patients, and then the feds can come in and then give you additional penalties on top of that if you weren't doing things right according to HIPAA beforehand. Okay, so this is the environment that we live in. Meaningful use had a really big impact on meaningful interoperability when during stage 2 of meaningful use, which if you're not familiar with meaningful use, it was $37 billion of your tax dollars going to doctors and hospitals to get everybody on EHR. Okay. Everybody with a caveat, because in pediatric world was largely not touched by meaningful use, and we still have some pediatric practices that are not on EHRs today, but it at least got most providers in the United States onto an EHR, many that were not before. So stage 2 of this, the government said, hey, we are going to have this continuity of care document with the data that you see in the light blue there. And so every EHR needs to be able to do this. And so if you are, for example, being referred from a primary care physician to a specialist, this is the type of data that the specialist wants to see on you. And that is going to need to come out of the EHR easily and quickly and go to the provider that you're going to, or just go to you, and you can have that data. Notably, what this did not do, this format was not in enough granularity to be computable on the receiving electronic health record. More about that in a minute. But at least this was a major step forward in interoperability a few years ago. Okay, we have all these common vocabulary and code sets. I won't take the time to go through this, but these tools exist if we use them correctly. It's sometimes easier said than done, because if different systems add different lab tests, because there's new lab tests coming out all the time, and they add a new lab test in their EHR and they don't call it the exact same LOINC code, then you still have problems with the semantic interoperability of the same lab test. I call this thing an apple, you call it an orange, even though it's the same lab test. So it's not easy, but at least we have a system for this. This is a key point. All right, you're not supposed to read this, obviously. This chart shows all the interfaces we have at Dayton Childrens. Oh, by the way, Dayton Childrens is a relatively small health system compared to a lot of other health systems. and that have even more complex environments and more hospitals and more clinical systems that have to integrate with their interface engine. So Epic's at the top, CorePoint is our interface engine at the bottom. A lot of this is internal hospital stuff, but some of it is patient-facing interoperable type of things, like you probably can't see it, but Well Health is in the sort of on the right-hand side, about 2/3 of the way down. That's our texting platform. It has very helpful integrations with Epic, and it helps us communicate with our patients for some things that have been around for a while, like appointment reminders. And then also it allows us to do some very sophisticated clinical workflows, like your kid's having surgery coming up. And so 24 hours before the surgery, we're going to text you with some information about some surgery prep or things like that. We can do some pretty advanced interoperability there. Okay, so we have a lot of capabilities here, and that's good to know. So, all right, so let's call that interoperability version 1. Then the government said, hey, we need to do better. We have this law, the 21st Century Cures Act, and on the 1st of May of last year, the final rule was published. Now, it had been talked about a long time before that, so it's not like it was a complete surprise last May. We pretty much had a good idea of what was coming, but this was really transformational. And this is a graphic that the government put out. What does it mean for patients? Ease of access to records, protecting patient privacy and security, and promoting the ability to shop for care and manage costs. What does it mean for clinicians in hospital? Making the simplifying the process of giving patients their records, allowing choice of apps, basically forcing provider organizations to give data to third-party apps, apps that the patient is choosing. Okay, yes, there's some implementation effort, but ultimately it's a good thing. It's going to improve patient safety. So what did this do compared to the data we talked about a few minutes ago for the summary of care document? Well, the thing that it added a few other things, but most notably clinical notes. So now probably you have you go to the doctor, you have a patient portal, and if you look at your patient portal, not all patients do. There's no reason that you have to, but if you pay attention to these things, possibly starting April of this year when this took effect, or possibly earlier if your providers had done this earlier, you now can look in and see all the clinical notes, okay? Also known as open notes, right? And this is called the US CDI, United States Core Data for Interoperability. And this is version 1 of that. And the beauty of this is that with the current standards, we can get this very granular, and we can then have a lot of this data computable on the receiving EHR end. Okay, so here's the timeline. Stuff at the top are these certification requirements that EHR vendors have to do. Stuff at the bottom, what providers have to do. So I mentioned the April date. It was supposed to be last November of 2020, and at the 11th hour, the government said, "Oh, just kidding. We'll give you till the following April, COVID related." And there was a lot of it was unfortunate they did it at the last hour. At Dayton Childrens, we went ahead with it last November because we had already trained all our staff, and we didn't want to have to train them again 6 months later. So we just ripped the Band-Aid off and made all the open notes available and the other things we had to do last November. But technically, it was not required until April of this year. Okay, and then looking forward, a year from now, which is we're going to spend a bunch of time talking about, is the definition of the data that needs to be shared is all EHI, all electronic health information. It's no longer limited to the data fields I just showed you here. It's basically going to be everything. More on that in a second. Okay, so that's the history lesson. Where we are today, where are we today in October 2021? Well, I have a couple slides here. These are training slides that we shared with our providers at Dayton Childrens. A lot of the sharing notes and when to share notes and when to unshare notes, there's some legal exceptions where you cannot share notes, like in the case of patient harm. This is a good example of this. It's really hard, and it's complex for all healthcare. It's a little extra complex for pediatric care, because you have the complexities of the proxy relationships for the person that's making the decision for the kid. It might be a foster parent, it might be a grandparent, it might be a divorced parent. You also have the complexities of adolescents that have rights to kick their parents out of their record at a certain age. And we have to respect that. And that's difficult to deal with the parents. We have sticky situations like this. You see on the left there, mom says to the doctor, hey, my husband's actually not the biological father of the child you've just diagnosed with inflammatory bowel disease. How does the provider respond to that? Well, there's different options. They can unshare the whole note, but then mom and dad are not going to get that note that's diagnosing their kid with this disease. Maybe it's irrelevant to the plan of care and they don't need to document anything about that. Or they can have they can do two notes. They have a separate note that documents just that, and that is unshared so that the rest of the care team can see it, but dad is not going to see that. Like, these are the kind of things, these are the kind of complexities that we have to deal with in the new environment with open notes. I'm not complaining about it. It's part of the journey so that we can share open notes with our patients. And there's a lot of data out there that says what a good thing this is for patient safety, because every so often mistakes are made. The patient sees there's a mistake in the note and can correct it. They would not have known that it needed to be corrected if they had not seen the open note. Here's another example. 2-month-old infant. The parents disclose they've been adding more water than is recommended to their baby's formula. There's a diagnosis of failure to thrive, but the provider is hesitant to document that because now, in the past, the parent wouldn't necessarily have seen that. Now the parent's going to see that note. And the only option in this case is you have to document that. And you have to explain to the family that you're documenting it, but you have to document it. There's no other option. This does not qualify for an exception criteria. All right. So this is what health systems are living today in the current interoperability. Okay. Let's geek out for a minute. We now have FHIR, Fast Health Interoperability Resources. It's this modern RESTful architecture for interface. And it allows much more granular exchange of clinical data, better privacy, better patient safety. And this is what enables the computable on both ends that I was talking about earlier. There's also an application framework that sits on top of the data that you can get in and out of an electronic health record with this FHIR standards called SMART on FHIR. SMART stands for substitutable medical apps, reusable technologies. Here's just one example of something that somebody built a while back, showing your kid's growth chart. And so what this does is it permits, from a technical perspective, a lot of great innovation. Because if you build an app that helps a patient do something, learn more, in this case, just a visual representation of your kid's growth chart, okay? Now you can tap into the EHR data that you couldn't tap into earlier. So there's a lot of potential here. And there is a lot of money going into digital health. So this chart is from Rock Health, one of the companies that is in the middle of a lot of this, and they publish this every quarter. They like to publish these charts showing the huge amounts of money going into digital health. As you can see, in the first 3 quarters of 2021, you've already got to $23 billion, far surpassing the $14.6 billion for all of 2020. And so there's a lot of money going into digital health. Now, some of that money is being wasted on dumb things that people are, investors, Silicon Valley investors are saying, oh, I'm going to disrupt healthcare and here's a check for $10 million and go do something. And it's probably never going to happen. But there's also a lot of really smart money going into this space for truly disruptive, truly beneficial innovation. You know where it's not going? It's not going into pediatric chronic disease management apps. I haven't seen any yet. So this is the Epic App Orchard. It's most of the major electronic health record vendors now have an app store. Anyways, Epic just happens to call theirs the App Orchard. It's a marketplace for apps that app vendors can coordinate with Epic. Used APIs, a combination of open APIs and proprietary APIs, have a contract with Epic, similar to how on your iOS app store, all these app vendors have an agreement with Epic or with Apple before it shows up on your iPhone, or an agreement with Google before it shows up on your Android, leveraging hundreds of APIs, and then support from Epic developers to make sure that this stuff actually works. And this is wonderful for health systems because in the past, we would buy something or we're thinking about whether we should buy something. And the vendor says, yes, this can interface with your EHR. Here's how we're going to do it. We're going to use this HL7 interface. And so going back to my chart earlier, the eye chart with our interface engine and all the interfaces we have, all the tools that are interfaced into our EHR, we would sometimes buy something and then find out that, gee, the interface process wasn't as easy as the vendor said it was. And we have to spend a lot of time getting that interface to work with our small interface team that always has too much to do. And so what's nice about the App Store is that we know that the vendor has already done a certain amount of homework with Epic to make sure that the interface is going to work. Does not guarantee that that app is going to do exactly what it says it will, or that it's going to solve all the problems in healthcare. But at least we can reduce we know that the level of effort for interoperability is going to be reduced. Okay, so very, very important advance in interoperability is the presence of these app stores and the number of apps that are not now on it. The number of apps on Epic App Orchard is up to 525 as of a couple weeks ago, when Epic had their annual App Orchard conference, where they invite third-party developers to come learn about how they can get on the App Orchard. Guess how many are focused on pediatric chronic disease that I could find? 0. There's a couple that maybe you could use on the peds side for chronic diseases that are adult and peds. There's a couple that are pediatric focused, not really chronic disease management. But this is part of where we are today with interoperability, is that we now have the tools with FHIR and the regulatory framework where everybody has to be doing that leveraging FHIR to enable easy export of a patient's data into a third-party app. And we have billions of dollars going into digital health, but we still don't have we still don't have, like, we'd love to have an asthma app or a juvenile diabetes app or a juvenile ischemic arthritis app or a cystic fibrosis app that we knew was going to integrate with Epic and help our patients and help our doctors. We haven't really seen that yet. I don't understand why. You would think that some of all that $20 billion would be going into tools like this, but it's not yet. So that's an important piece of where we are today in October 2021. Okay, now let's talk about where we're going. So a year from now, we have to open up to all EHI, not just that US core data for an interoperability data set. This slide is a slide that I presented to our leadership at Dayton Childrens at our, every month we have a IT governance committee. And most of the time we're making decisions about what should we buy? Are we gonna implement this new module of Epic? Are we gonna buy some other new IT vendor? But I also try to keep them up to date with what's going on with important topics in healthcare IT, and obviously interoperability is an important topic. So this was my slide that I presented to them just a couple weeks ago at our October meeting. Notably, after we started looking in April when we enabled that the FHIR interface for patients, we could look in our system, of course, and see when a parent has downloaded their kid's record into a third-party app. Download may not be the right term. Transfer their kids' data into a third-party app. Okay, you can see the dates there. You can see the applications mentioned. Both of those are applications that are sort of a, if you look at their webpage, they're basically a clearinghouse for, hey, you got 5 doctors on 5 different EHRs. You want to get all your data in one place, you can use our tool and get your data in one place. And then maybe you can plug it into other tools from there. Okay, so at the end of April, we had 2. I sort of expected that we would see that slowly grow over time. You know, we found out 0. There's been 0 people transferring their kids' data into third-party apps using this new tool since April. I find that odd. Once again, you would think that this would be growing now that we have all this great capability, but it's not. It's not growing very fast. Okay. Now, I should mention that on the pediatric side, typically some of the investment and some of the innovation happens a little bit slower, because if you are a vendor and of course, you want to get a return on your investment that you're building this app, and oftentimes the dollars flow to adult medicine before pediatric, just because there's more adults than there are kids. And so some of this may be related to pediatric health. I still find it odd that we don't see that ramping up. Okay. So then I also explained to our leadership, hey, a year from now, we are going to need to release to patients basically the entire electronic health record in something called the designated record set. More on that in a minute. And in a near real time fashion, because that's what the government said. More on that in a minute too. And when Epic talks to their customers, to their health information management departments, which is basically the equivalent, if you're not familiar with that terminology, that's the terminology today for that first job. My first job in healthcare in 1996, the medical records department. That's basically the medical records department now. Okay, and the legal definition of designated record set gives health systems a little bit of flexibility into what is considered the designated record sets when they are today releasing this data the old-fashioned way. Maybe a lot of PDFs on a CD that they're handing the patient. Okay. And so Epic said, hey, we got to go talk to our customers, because if we're going to have to now do an electronic release of all this data, we got to figure out what we have to build. Okay. And what they found is that there's a lot of disagreement about what actually ought to be in that designated record set. Okay. If the law gives you the flexibility to include some things and not include other things, and you're doing that release of information the old-fashioned way, okay, fine, no big deal. if you're trying to build this capability as an EHR vendor, it's sort of a bigger deal. Well, what do you actually put in there? Okay. And what's going to happen is the patients are going to get a zip file of thousands of files, which is really the only way to do this. And we'll dive into this. Okay. Bottom line is it's a massive effort with probably small usage. So if we're getting very little usage of data, to go back to the top of the slide, if you're getting very little usage data that is computable in a fire, that's granular in a fire standard, that can easily be brought into applications, and nobody's really using that, why do we think that anyone's going to want to do anything with a zip file with thousands of files in a technically computer readable, because it's electronic, and we'll have a README file to tell you, a really long README file to tell a developer potentially what to do with that. But I'm really thinking that this is going to be and not just me, other people way smarter than me that are looking at this. I think it's going to be a really small usage. So that's what's coming. All right, designated record set. Here's the legal definition. If you read lines 1, 2, 3 there, it's pretty much everything. Now there's some carve outs. Does not include psychotherapy notes. Does not include data that is captured in reasonable expectation of legal proceedings. Does not include some quality improvement. There are a few things to carve out, but basically it's supposed to be mostly everything. Okay, this is the result of Epic's talking to HIM departments that I mentioned a minute ago. As you can see, there's some major disagreements about certain things. Okay. For example, provider messages. Most EHRs have some kind of secure chatting between providers, or between a nurse and a provider. 50% people said never, and then a quarter said always, a quarter said sometimes. Okay. Patient transportation, disagreement of that. Pharmacist intervention, disagreement about that. Clinical decision support history, disagreement about that. Like, the industry can't even agree on what this designated record set should be. And here we are, we're supposed to be moving fast to put all of this in place a year from now. Like, maybe we should figure this out. Maybe there should be some sort of standardization for this designated record set. It's basically a hot mess at this point. This slide is actually a slide from Epic. By the way, I'm using a few slides from Epic. I have permission for them to do this. And I'm talking Epic unapologetically, because bottom line is in Central and Southern Ohio, all the health systems, the vast majority are on Epic anyway. And so I think this is of general interest to the audience. Okay, so there we go. A year from now, info blocking of EHI is prohibited, and I put information sharing at the top of this because that is what the leadership at the Office of the National Coordinator, the federal agency that works with all these regulations, that helps set all these regulations, said, hey, let's stop saying information blocking. Let's start saying information sharing. Let's do the glass half full. Okay. Okay. So great, information sharing. So a year from now, we're supposed to share basically everything in the record. Notably, the boxes you see on the right that mention B10, that refers to the exact requirement for the EHR certification. That's the CEHRT. And so the government is actually saying you have to stop blocking all EHI in October 2022, but the EHR vendors are not actually required to be doing all of this until later. And oh, by the way, there's always there's a delay between when the EHR vendors have it ready and when your average health system can do the upgrade to that EHR. So really, this doesn't line up at all. You sort of need to have this capability in the EHR. Now, we're lucky in Epic world because Epic typically gets this done. That's the blue box on the bottom. They typically get this done before it has to be done because they're tracking all these federal regs. They want to make things, you know, as easy on their customers as you can. They got a big development team. So they're working on this really hard. They hope to have this capability in late 2022. Okay. But this basically makes no sense that you've got this requirement before it's really required for the EHRs. What kind of format? Let's talk about the format for a minute. So we have had a human readable PDF format for a long time. Going all the way back to my second slide, that form you fill out, you say, I want to get my kid's data for related to this surgery or this inpatient stay between these days, or I want the entire record. Okay, great. Here's a lot of PDFs on a CD for you. Okay, that could be selected portions or it could be all. We're talking the standards-based, the CCDA, it's been around for a while. The FHIR, that's relatively new. That's by definition a subset of all the data, because when you take a standards-based approach to make it truly computable, you have to go, you have to do a little bit at a time. Okay. So what's going to have to happen is a non-standard, and it's really important, non-standard machine readable. Machine readable makes it sound like, oh, that's great, all the machines can talk to each other. No, it just means that it's all the machines can theoretically talk to each other if they can understand the format that it's in. But if it's non-standard and every EHR vendor is going to be doing this slightly differently, it's basically an impossible task for any developer to figure all that out. That's the problem. Also, the government, in spectacularly unhelpful fashion, answered a question about how fast are we supposed to do this? Because today we are supposed to be able to deliver a patient using those FHIR standards for the US core data for interoperability, that data set. We're supposed to do this basically instantaneously, and we can. Okay, so if you're telling us now we have to do everything, how fast are we supposed to do this? What do you mean by timely? And the government said, thank you for your question. We specify that timely means near real time while being reasonable and prudent given the circumstances. Well, those two things do not go together, okay? So it's not going to be near real time given what has to happen. So once again, government's not being particularly realistic about this. So this is also from the Epic presentation. You're going to have several hours. You have this massive data collection out of Clarity and the blob server. I know I'm getting into some Epic speak here. For those of you that are not familiar with Epic, it's not going to make sense. I won't describe all that. There's no point in that right now. But that is going to take a while. And then, oh, by the way, you've got electronic health information in other systems besides Epic that are part of the designated record set. And so you're supposed to collect that from other systems. So it's going to take a while. It's not going to be near real time. So we're going to have this zip file with thousands of files, tab delimited files, CCDA files, files in the blob server format, like scans of PDFs, images, medical images, a README file so that somebody could theoretically make sense of this if you have a giant development team, okay? who is this really going to help? So I was talking to somebody, I won't say their name, but they are on the Healthcare IT Advisory Council, which is the group that meets and advises the government on how we should be doing all this, made up of interoperability experts. And she was saying that there's huge political pressure to free all the data, including communities such as researchers, because researchers say, just give us all the data and then we can cure all these diseases because we're going to, we're going to do great research. We're going to put all this data together and do artificial intelligence, or we're going to solve world hunger. And she was describing to them this type of a format that's necessary. And when they got their head around this, they said, oh yeah, that's not really going to be helpful. So we've got big political pressure to free all the data. But it's going to be in a really not helpful format, but we're doing it anyways because there's political pressure to do it. So that's what's going on here. So I've come up with a very advanced data visualization to describe the problem here. Here it is. Is that coming through okay? I don't know if the GIF's coming through on the Zoom, but anyways, it's a train wreck. It's going to be a train wreck. It's going to collapse of its own weight. We're still in a pandemic. People are not paying attention to this. We're going to go through this massive amount of effort and for not a lot of benefit. Why are we doing this to ourselves? It makes no sense. Okay. What we should be doing is taking a standards-based approach. We should be moving aggressively to expand the definition of that US core data for interoperability that is standards-based, FHIR-based, and therefore truly computable. Okay. This gentleman here, Wes Richel, he's one of my healthcare heroes. He's retired now. He was a Gartner analyst for many years, and he used to start his presentations like 5 years ago. Before we really got into where we are today with FHIR, he would say, I've been working on healthcare interoperability standards for 30 years, and I hope we have some soon. And of course, that would get a laugh. Well, we've come so far, and yet here we are about to make, in my opinion, and I haven't talked to Wes recently, but I'm guessing in his opinion, a huge mistake. And so what we could be doing and should be doing is, so we're on US CDI version 1. There's a US CDI version 2. If you follow the link on the slide, there's a very interesting discussion so the government is asking for comments on US CDI, and some of the comments for version 2 specifically, I'm sorry. So they're expanding the data that's going to go in here. And some of the comments are saying, this is great, but you need more. You should be expanding it faster. You should be adding this data and that data because this is going to be useful for a lot of people to get in a computable format. So I would think that the smarter way of approaching this would be to slow down on the garbagey export of all EHI, aggressively expand the US CDI that is computable, and take a step back and figure this out. But I don't know. I don't think they're going to listen to me, but that's what we should be doing. Okay. Let's talk about a few other things here. Digital health marketplaces, can they improve interoperability? I've seen this just recently. This is just earlier this month. This is a group of notable health systems, Intermountain, Presbyterian, SSM Health, and they said, hey, we're going to have this, we're launching Graphite Health. It's a health system-led nonprofit company to accelerate digital transformation. We are going to test out all these digital apps that are going to connect to your EHR for you. And this is going to help solve interoperability challenges. Okay. Another one, Panda Health. This is sort of a GPO model, group purchasing organization, where they say they are associated with Vizient, which is one of the large healthcare group purchasing organizations. And they said, hey, we've vetted all these apps. So you, the health system, sign up with us. We've already negotiated the prices with these vendors. We've already done the security screening for these vendors. And so we did all the hard work, and now you can just come into our store and buy these digital apps. So this is something that's coming in. The point of this is that it's separate from the EHR app stores. Now, those vendors might also be on the EHR app store, probably are. If you're on Epic, you probably wanted to be on the Epic App Orchard before you buy any of these, however you're buying them. But at least there's a lot of thought going into how can we make this process easier. This is from a story about the launch of Graphite Health, about what it is they're trying to do. But I don't necessarily agree with all of this. The third bullet there, health systems take years to adopt and integrate new apps. We're going to help you do it faster. Well, that used to be true, but with the App Orchard, it doesn't necessarily have to take that long anymore. And then also the CEO said, of Graphite said, there's no reason to do independent security reviews. Well, you still have to do it. You still have to do a security review because you're the one on the hook if that vendor turns out to have a problem. It's certainly good to have somebody else do a security review before you do it, and maybe you can look at that and make that process go faster. And there's ways of doing that, but you still have to. Every health system still has to do a security review. Okay, so let's see. Let's do a time check here. All right, we got a little time left. I'm going to go through what does this mean to you as a patient, benefits and the risk. Very important to understand. All right, pop quiz. Is it a HIPAA violation for you to post your medical records on the interwebs? Answer: no, because self-disclosure of protected health information is not covered by HIPAA. That is a very, very, very important point. I do not recommend that you post your medical records on Facebook, but if you decide to do that, that's not a HIPAA violation. You decided to release your records. Okay, so the screen you see here is something that Epic customers, when a patient wants to export their data out of a provider of theirs that's on Epic into a third party, what Epic has done is have that third party vendor answer some questions, things like who's offering the app, where's your data stored, do they allow you to obtain a record of data that has collected about you, how is it funded, who has access to your data, and can you delete the data that's stored about you. Okay, types of patient rights, sorts of things that you ought to know. Okay, and then it says, okay, you move forward, this vendor is going to have your data for these types of data until this time. Do you acknowledge that you understand all this? And then you can allow access, and then that can happen. Okay, so this is what our patients would have gone through. The two patients that I mentioned did this in back in April. They went through a little process like this. Okay. So this is just something to be aware of. So that's good, right? You can look on the App Store. You can find an app that helps manage your chronic disease. You can download it. You can go through that process. That's all great, right? Well, some things to be aware of. So yes, it's good. It is very good, but be aware of some things. One, there's massive fraud in healthcare. The bad guys are out there bilking the government of billions of dollars. How do they do that? They steal data. Because if you're going to bill for healthcare services that you haven't really provided, you have to have real patient data, that patients that actually have health benefits, like Medicare, notably Medicare, in order to commit fraud. And so there's a big market for that. So there's big incentive for the bad guys to get your data. Also, somebody did a study of some of these new apps. And so the good news is we've got these great APIs that can share this data. The bad news is with any new technology, there's new security holes. And they found that a lot of these apps had some major security holes. They were able to get in and basically steal data with the same APIs that they're using. They didn't have good security controls. Okay. Then we have Cambridge Analytica, which, if you don't remember from a few years ago, was a company that got a lot of data out of Facebook using the system that Facebook had It was sort of an app to sort of trick people into giving up their data. And then they used that for ultimately illegal purposes, and they ultimately got in trouble. But they collected that data using the system that was set up to collect data. In other words, it was they ultimately stole the data, but they did it in a way that was within the system. So there's a huge risk here in healthcare. Okay, the feds are beginning to pay more attention to this. The Federal Trade Commission recently came out and said, "Hey, you app vendors, you may not be you may not be beholden to Hipaa because the patients have given you their data, but you still are responsible for the health breach notification rule if there's any health breaches." Okay. However, that is the big but to this, is that that's not helping you as the consumer. So you have to understand that things can go wrong here. And so A, don't be afraid to ask your doctor that you now have the right to download your health records to your apps. Make sure you read the small print. We are also conditioned to adding an app on our phone and going through the small print and saying, yes, 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 yes. This is different. This is your health data. It's really important. Make sure you read the small print. Make sure you understand where your data is going. If you have concerns about it, don't do it. Make sure you carefully consider the risk versus reward. Last couple slides. What about if your record is de-identified? This has been in the news recently. So what if Google's listening and they're de-identifying the data and putting it in some big research database? Congress got all upset about this recently. You know, I really think this is different. If it's de-identified, there's a lot of benefits for research. Epic has a research database called Cosmos with over 100 million patients. We at Dayton Childrens, we contribute our de-identified patients data into this. And this has allowed a lot of really good research very quickly during that pandemic, because this database, which was basically going online right about the same time the pandemic hit. And so this is, if you hear about this one, I would say don't worry about that. Do be worried about exporting your data into some app vendor. Make sure you trust that app vendor. Don't be worried about the de-identified stuff. There's a big benefit there. Okay, all right, we have a few minutes left for questions.
JD, it looks like we have a question here in the Q&A. Completely agree with your assessment today. Are you aware of any discussion or delays of updating to the standards approach?
I have not heard that yet. I can only imagine that once more people get their head around this, there will be some delays, but no, I've not heard of anything.
Okay. And I'll just throw my own question out there as well. Having, working at the Health Collaborative, one of the Ohio HIEs, and I see several of my colleagues on today from CliniSync. It's interesting, those in the interoperability space, you commented a few times in terms of format of data, but I often also think there needs to be some standardization to content of data, because, patient weight, height and weight aren't standard, right? And we can all agree what field to put that data in, but if somebody puts it in kilograms and somebody else puts it in, pounds or ounces, it all means something different. And I know just from our own organization, struggling with even ICD-10s, and you would think that's standard enough, but some send it with the periods, some send it without the periods, Right. So any thought, conversation to add to that?
Yeah, just that, yes, despite all of the advances with FHIR, you still get into those types of the subtleties of the semantic normalization stuff, right? And right, the HIEs have been dealing with this for a while. And so I don't know if Alex, do you follow Dale Sanders?
A little bit.
Yeah, he's a good follow on social media. Another former Air Force guy. And he recently moved from Health Catalyst to IMO, Intelligent Medical Objects, which is actually a vendor of ours. And his big thing is this data quality and exactly the issues that you're talking about. Specifically, that the AI can't do its magic until we get all this data cleaned up, right? And it's easier said than done, and we just need to keep at it. And that looks like different things. That looks like individual health systems making sure that the data collection is done right, and then also some industry standard things. And are we calling that new lab test the same thing in the line code? In Epic world, some of that semantic normalization stuff that people needed to do in order to supply data to the Cosmos research database, which I think most of the Dayton, Cincinnati, Columbus health systems are doing now, required some of that LOINC code and other mapping that theoretically makes some of that better. And then so some of the Epic Care Everywhere exchanges that we have are supposedly better. So
No, makes sense. Well, and even what we saw during COVID, I'm just sharing our own example, working with the Ohio Department of Health during COVID, with race, ethnicity, and patient sex. Just that posed quite a few challenges. And, it was interesting because early in the pandemic, we all wanted intel, right? The media hounded everybody for intel, right? But it was a mess, even just to report on something.
Yeah. Oh, by the way, in the middle of a pandemic, when you've got a lot of crisis things going on, adding data fields but adding demographic data fields in places that they weren't previously, and expecting what would normally be like a 2-month integration process to happen overnight, it does not actually help anything, right? That we made some mistakes there. So.
Well, and I'm going to shamelessly steal an example from Mickey Tripathi, because we had him come out, and many of you recognize he's the new head of ONC. And he came out to Cincinnati, gave a presentation probably 2.5 years ago, and used an example when you were sharing with us on FIRE about he used the example of, I download, say, my Apple Health app, and I want to access all of my patient records wherever I have been seen. So I've got now all that data on my phone, and my Open Table app says, if you'll allow me access to your Apple Health app, I can actually give you guidance on restaurants that fit your dietary restrictions and needs. Do you want to give me permission? Mm-hmm. And of course, most of us would say, sure, why wouldn't I want, very personalized recommendations on restaurants? But then once that data is now accessible to my Open Table app and others, right, my fitness apps, et cetera, suddenly that starts to fall outside of HIPAA. And, same comment you just had, I love that, of, okay, what does that mean to this world of now my data could be accessible anywhere by anyone? And
Yep, it's scary. And the minimum necessary data thing, I got a story about that. We were working with a vendor that was basically going to be the go-between with an electronic signature vendor, so that if for example, we need to collect a patient consent from a parent, and the parent lives 2 hours away, be nice if we can do that in electronic signature, right? And so we had the go-between vendor that was going to pass the patient demographic data so that the e-signature vendor could do their thing. And we looked into that, and they were going to deliver the entire CDA document to the signature vendor. And we're like, no, that's wildly inappropriate. That's a major HIPAA problem. And this was like a, respect. Before I learned that, respectable vendor, that as one of these go-between vendors that says to the app vendors, hey, sign up with this and we'll get you the EHR data. So you have to, going back to that independent security review, you have to be looking hard at this stuff, because the good news is we have all this great interoperability. The bad news is it's opening Pandora's box for other security issues.
Yeah, very good. Totally agree with you. So in the matter, I don't see any other comments or questions here in the chat. So JD, I appreciate you getting a chance to join us this afternoon. Any final comments you have for this audience in terms of how do we then start to, encourage either our legislators or others to, like you said, pause, let's regroup on this topic, let's determine what the right solution really is. And so where do we all fit in that? How can we do that?
Yeah, I think from a health system perspective, we all have our government relations people that are handle some of this stuff for us. And so if we as the healthcare IT experts can educate our government relations people and just senior leadership about this, that hopefully if enough people are saying things to ONC, then hopefully we can do something before, so they don't have to do what they did last time, which was wait to the 11th hour and say, oh, just kidding, move it to the right by a year. So yeah, and then at an individual level, just be careful about what you're clicking on your phone. That's the big takeaway there.
Absolutely. Read the fine print, right?
Read the fine print. Mm-hmm.
And I see a comment from Ajay in here about maybe this is our theme for Advocacy Day coming up in the spring.
Absolutely. Totally agree. Yep.
Start to educate our legislators. I like that.
Good idea. Mm-hmm.
All right. Well, on behalf of CSOHIMSS, JD, I really appreciate it. Really compelling discussion today.
Thank you. It was fun.
Yeah, great.